Welcome, everybody. You're not seeing me, but this is Barb Cochran. I am the Associate Director for the Northwest Geriatric Workforce Enhancement Center, and I am pleased to welcome you to our second to the last presentation for this winter term geriatric healthcare lecture series. We will be having another lecture series starting up the first week in April, and you should be getting information from your site coordinators about those lectures. They're going to be focused on more general geriatric topics as opposed to cognitive impairment and dementia and Alzheimer's disease. But today I am happy to introduce Kris Fredrickson. Kris is a passionate advocate for older adults, those with neurocognitive disorders and other disabilities, in her role as a clinical social worker at the Seattle VA Primary Care Services and Geriatric Research, Education, and Clinical Center, where she's been employed for 15 years. Her previous work in the inpatient and outpatient mental health and jail systems provided her with a unique, and I would believe that, understanding of the need for advocacy, education, and supporting navigating the complex connections between them. Kris is a dedicated educator of social work graduate students in practicum placements and committed to educating professionals and families. She has obtained a geriatric mental health certificate from UW. She participates in several demonstration projects at the VA, developing group treatment and educational programs. And she's been a member of the King County Elder Abuse Council and the Advisory Council for Aging and Disability Services. And I think you can see why she is just the expert to talk to us today about elder abuse, neglect, and cognitive impairment. What do we do? Welcome, Kris.
Thank you so much, Barbara. I'm really honored to be asked to talk with you today. And this particular talk is one that I really enjoy giving because there's ever-changing information and more information is coming out about how we really can assess, diagnose, and intervene on elder abuse. In fact, I just read something today about a new tool that was just developed to assess. So that's kind of exciting, continuing progress in that regard. So I wanted to talk to you about the learning objectives, to discuss the definition of vulnerable adult and the role of adult protective services, to identify the types of abuse, neglect, and exploitation, to explain the interventions available for older adults experiencing abuse, neglect, or exploitation, and identify the risk factors and caregiver profiles, and discuss the professional responsibility of mandated reporters. There will be questions at the end. You can write them in on the screen.
Oh, thank you.
So I wanted to start with a few numbers. Some stats: between 1 and 2 million Americans age 65 or older have been injured, exploited, or otherwise mistreated by someone whom they depend upon for care or protection. Pretty startling numbers. A comprehensive review found that the prevalence of elder abuse to be approximately 10% across the board. Physical abuse, pathological abuse, or psychological abuse, verbal abuse, sexual abuse, all the kinds of abuse. A 2010 study found that 47% of participants with dementia had been mistreated by their caregivers. Of them, 88.5% experienced psychological abuse, almost 20% physical, and almost 30% neglect. So this is out there, and we are hoping to become better and better at screening and intervening. We know that the costs of these types of abuse are rising, and they contribute significantly to our medical provision out there in the community. Costs of injuries are estimated to contribute more than $5.3 billion to the nation's annual health expenditures. So that's pretty huge. And we already know that older adults are using the emergency rooms often for medical care as well. So we have a great burden on the emergency rooms, and primary care doctors are seeing this show up to them as well. And because they're often isolated and have few support systems, the impact of abuse can send them down a very difficult path, often ending in significant illness and hospitalization and even death. The Administration on Aging expects the over 65 population to double between now and 2030, and with the older adult population being 19% of the population. So that is definitely something that nobody is going to be missing. As we see here on this graph from the Census Bureau, the percentage of 65 and older with a disability is growing and growing. And when we find out about one, we know that 24 haven't reported and are not known. 24, that's pretty astonishing. So there's always a lot more going on than we know about. And we need to be better about screening and detecting and even keeping an eye out in our communities for folks that we're not providing any kind of health care to as well. The definition of elder abuse for the purposes of the state law here is willful action or inaction that inflicts injury, unreasonable confinement, intimidation, or punishment on the vulnerable adult. In the instance of a vulnerable adult who's not able to express it, the abuse is presumed to cause physical harm, pain, and mental anguish. And so that kind of ties back into our cognitive impairment when we've got those veterans and older adults who cannot talk about this. We're just presuming that it is harmful to them and acting as if, and you'll see a little bit more of that later as we go along. So a vulnerable adult, according to the RCW, is 60 years or older with the inability to care for themselves. That's kind of the basic criteria. They also can be incapacitated, not able to take care of themselves, developmentally disabled, or admitted to a facility, or receiving licensed health care in the home, like hospice, or they've hired an aide, receiving services from DSHS or a contracted provider by them. So if they're receiving COPS benefits, and a person who self-directs their own personal medical care. So even if they're hiring somebody, hiring a family member, hiring a professional in the community, they can be considered a vulnerable adult if they are unable to take care of themselves and are 60 years or older. So throughout this, when we're talking about abuse, and exploitation, we're talking about multiple different kinds. I just want to review this quickly. Physical abuse is intentional harm. This is intentionally trying to harm someone. Psychological abuse is intentional, again, physical harm, mental harm, or psychological distress. Violations of basic rights are included in the psychological abuse and are protected under the law. Federal and state law, by the way. Sexual abuse is any sexual activity for which the person does not or cannot give consent. So if a person is cognitively disabled and isn't able to state whether they consent or not, they are assumed to be a vulnerable adult and exploited or abused. Financial or material exploitation. Well, this is the one that crosses my desk most of the time. And I'm learning more and more how to look after the caregiver when they come into my office and are trying to figure out what is going on. And we'll talk a little bit more about that in a few minutes. So here we're talking about neglect. And there's two types of neglect. There's self-neglect, where the caregiver fails to meet the obligation to care for the person. And there's passive neglect, which is unintentional. There's also self-neglect, which is failure to meet their own, take care of their own personal care needs and take care of themselves. Uh-oh. Oops, sorry, had a little stuck key there. Okay. So with self-neglect, often I get asked this question: if an individual is not found to be legally incompetent by a judge through a guardianship process, but chooses to neglect their personal health or safety or refuses appropriate care, is this self-neglect? And does it warrant reporting or intervention? And again, as we talked about, just because they can't tell us that they're neglecting themselves, still presumes that if they're not taking care of themselves and their basic needs, that they are. And it is reportable. So self-neglect, as you drive through the neighborhoods, you can see the homes that have stuff piled up to the roofs and things stuck to the windows, and often see that that person is hoarding items in their home, or their front yard is covered with things. Those folks are often self-neglecting. They're often not able to use their kitchens as they're intended, their bedrooms as intended. They're not able to get around in their place. Consequently, their hygiene suffers, their ability to make themselves food suffers. And so that's a very common one that we see. What's sure going on with my slides here? Sorry about that. So who is the person who is self-neglecting? Well, lots of different folks are self-neglecting, and lots of different folks are being abused. In terms of risk factors for abuse, most often they are female, which is very interesting. Often they're physically and medically disabled. Often they are diagnosed with some cognitive impairment, as we know, and socially isolated, unmarried, don't have very many folks coming in and out of their lives. They may have children that have no contact anymore because of their self-neglect. They may have a caregiver that comes in their home paid, or somebody who actually lives there, often a child, a grown child. History of previous trauma. So where you see one form of abuse, you often see multiple forms of abuse. And so whenever you're confronted with one form of abuse, it is important to assess for those other types of abuse, even if they don't report them. Again, just because they don't report doesn't mean they're not a vulnerable adult and being abused. So let's talk about Mrs. A. Mrs. A is a 92-year-old African-American, World War II veteran, divorced for 30 years. She's diagnosed with Alzheimer's, arthritis, stage 3 kidney disease, macular degeneration, and a history of falls. Her son, her 65-year-old son, lives with her and her adored pet poodle, Killer, and helps with her ADLs and her IADLs, including money management and cooking. Mrs. A, she says she's losing weight because she doesn't eat very much and doesn't like the food. Her son brings her to the clinic and wants her pain meds refilled. So this is very often what comes to the primary care service, and or the son says that the person is having disturbing behaviors at home, and they're coming to the geriatric psychiatry service wanting to know, is there medications that they can get for these behaviors to stop these behaviors? But my ears prick up immediately with that she is losing weight and she doesn't eat, but yet the son is saying that he prepares the food for her. So this is a situation in which I definitely would want to know more. I would want to know more about the son, and I would want to know more about Mrs. A and her day-to-day functioning abilities. So with Mrs. A, we have to think about, is she being neglected? Is he not taking care of her appropriately? Is he causing psychological abuse? Is he withholding things from her? We have physical abuse. Is the son doing something to cause her physical harm? Is she anxious? Is she worried? That's why she's losing weight. And we'll talk more about these symptoms in a moment. So when we, oh, pardon me, I skipped a slide there. when we're talking about the victim and we're starting to look at these things, we're looking at those personal care and hygiene and how she's taking care of herself with dehydration. Is she being prevented from having water? Is she not drinking it herself? Very often these older adults who are in their upper years are not used to drinking a lot of water. It's not as prevalent as it is now. And so I run into a lot of veterans and their caregivers who have a lot of trouble drinking enough water to stay undehydrated. And often they come into the emergency room because they are dehydrated. And we have to talk about that, drinking more water. So is this a situation with Mrs. A in which she's not being given it, or is she not taking it on her own? Does she have any kind of wounds that we know of? Does she show any kind of sense of being neglected, in being left in a chair all the time? Being left in a chair without giving her blankets and pillows and comfort items? Is she being abandoned? Is the son gone from the home every day and leaving her completely alone to figure out her own food and water, and she may have some physical disability that prevents that? There's lots of questions we begin to ask when we're sort of sorting this all out. In terms of a neglect as well, one thing that I see is caregivers who call me up and say they're at their wit's end and they want to just come drop the person off at the emergency room and never care for them again. And I often have to educate them about what abandonment really is, and that there's the opportunity to work to develop an intervention plan, we'll talk about later too, and that they shouldn't just neglect the person by leaving them and not coming back. But there's a way to work with and develop interventions with the treatment team and help them out in that way. Okay, so the next thing we look at is the perpetrator behavior of emotional and psychological abuse. So perpetrator behavior, so we talked about keeping them in the home, locking them in. Other things can be like keeping their mail, not allowing them to have what is mailed to them, refusing to take the person to a doctor. Maybe they show up at the clinic, the son is asking for the medication refill, but you can see that she's got some old injuries and she hasn't been treated appropriately for those old injuries. She may have signs of abnormal labs and wondering, why is that happening? If she is a person who has been to a number of doctors, he's taken her to a number of doctors for kind of doctor shopping, finding a doctor that won't ask too many questions, finding a doctor who will refill meds easily without screening, things like that. And then the perpetrator often will blame the victim for what's happening to them. Oh, well, she was doing something that she shouldn't have been doing and she fell down the stairs, or she didn't eat the food when I gave it to her, or failure to allow even caregivers in the home. Oftentimes at the VA, we will send caregivers to the home, and sometimes the family doesn't let them in. And that is often the first person who's sort of aware that something is going on and more needs to be investigated. All right. When we're talking about material and financial abuse, this one comes across my desk often, and it's often difficult to figure out because the person has the cognitive impairment and isn't able to really negotiate banking systems, isn't able to follow through with getting documentation. Sometimes they don't even remember that they've been to the bank maybe multiple times a day and withdrawn money. So sometimes you'll see the bank teller will try to contact family and try to say that they've seen the person at the bank multiple times, and was the family aware that they were taking out money repeatedly and didn't seem to remember. You also have the person who is being abused not having any money. sort of living below their means. At the end of the month, they're saying that they don't have any food in the house. Maybe this is what Mrs. A is going through. She's living below her means because the son is not allowing her to spend her own money. So we start asking all of these questions. Sometimes family members or caregivers won't take the person to the bank. They don't have access to the bank, and they're not able physically or cognitively to get there on their own. Sometimes we see folks that come in and have, for the first time, mentioned that their electricity is off and their car was towed and they don't know what to do about it. And you find out that the electricity has been off for quite some time and they never said anything about it. Sometimes because they don't remember, and sometimes because they just weren't able to tell somebody for whatever reason. And then it becomes sort of an investigation about what's going on, where are they in the notice process, and how do we get these services back to this person, or how do we get the person out of the situation and into a much better situation. There's a term in the law now that, the law field now, that is being used a lot for these types of abuse cases and financial abuse particularly. It's undue influence. Any act of persuasion that overcomes free will and judgment includes things like insinuations, flattery, trickery, deception, any of those things that a person might do to influence someone else into going against their normal, what they would normally decide, their normal decision making, their normal process, to allow somebody to take over their money or to invest that money into something else. Or, there's many, many, many different kinds of things that a person can do, but ultimately they often land the person with their money, their resources gone, often their homes. If they've got somebody like this that's kind of manipulating them, they'll deed their home. They'll take out extra money, second mortgages. I had a patient one time who the son found out that the other son was not caring for the veteran very appropriately, and soon discovered that the veteran had 5 mortgages on his, what he thought was paid off house. And somebody had been talking him into all these mortgages, and the person didn't remember. Every time they called them, they didn't know that they'd had a conversation before, and so he had to try to dig his father out from under this mess, and it took quite some time to be able to do that. And of course, he had to seek legal remedy and assistance to kind of push that forward and get the veteran back into financial shape. So you often see this show up with scams, and Seattle is an area that is particularly rife with scams, with the organized professional kind of scams. Everything from folks that will walk up to the door and say, hey, can I fix your roof? And then they try to get into the house, see what kind of valuables the person has, and then make a plan for stealing their stuff or their money. And they don't really fix the roof very well either. Same thing with driveways, other types of house repair. There are sweetheart scams. There was just an article in the newspaper about sweetheart scams that very organized groups will target elderly folks in the grocery store or grocery store parking lot and try to help them put their bags into the car and start up a conversation, and little by little develop a sweetheart type relationship with them, in which they become that person's significant other, and they begin to swindle them out of many, many financial and material resources. We have all kinds of sweetheart scams that are going on here, and oftentimes, particularly with older adult men who are captivated by one of these scamming females, they often feel like they can't tell anyone because they feel so embarrassed that they got duped, that they should have known better. And if they tell their family or friends, then they're going to get put into a nursing home because that will be a sign that they can't take care of themselves. And so often they don't tell. And, it's almost too late sometimes to get that information. So I think particularly there's been a number of things that have landed in the news and on the newspaper recently about these folks who've been really swindled out of everything. And so I know for my practice personally, beginning that conversation right away about financially assessing, how are they doing? Do they have money at the end of the month? That kind of thing. Very important to get going right away when you have the person with you, because you may not know when that person is going to be able to be assessed the next time, and who knows if they may, not have any finances left at that time. There's two resources on here, the Federal Trade Commission and AARP. They both have very good websites on scams and fraud, and they have guidelines to report various fraud and scams, and they are seeking legal remedy, as well as the Attorney General of Washington. They do have an elder law department with the Attorney General, and have been for years. Actually, we're very gifted in Washington and King County particularly to have had this service through the Attorney General's office for many years, with an elder abuse department that has attorneys, and they have connected with police officers on that specific unit to sort of go after these abusers. And so we're really fortunate. So check those websites out if you like. So here's an example of a situation that I found out about. It was in the newspaper in 2013 that a woman was prosecuted for restraining her 89-year-old mother in a cage-like structure that her boyfriend had made. They said in the article, "We weren't trying to harm her, we were trying to keep her safe. It was an ill-advised attempt to help keep my parents and the family together." So the veteran was restrained, and the gentleman was not restrained, but he was not to the point where he was wandering, which was causing them the most amount of anguish. The thing is that this woman was a physician, practicing physician. And when I found out this happened, I was amazed because I had dealt with this family for years. There were no outward signs that anything was going on. The parents, neither one of them, were really cognitively able to express what was going on, and we couldn't get very much information out of them directly, and so we missed it. And when I found out about this, I was shocked. The only way that it was detected was that we had ordered a nurse's aide to go into the home to help with ADLs. And as soon as they walked into the home, they saw the cage, and they reported it to APS, and it rolled on from there. But previous to that, we didn't know about it. And it was sort of a wake-up call for me to be much more diligent in how I ask questions when I have the person in front of me. Because we never know. With cognitive impairment, we never know. That may be the last time that we see that person who's able to answer those types of questions. Or if they're, up in their years, we may never see them again. They might just go home and not be able to come into appointments anymore. So this is certainly things like this are going on out there, and so many of them are not known. So who are the folks who abuse older adults and older adults with cognitive impairment? We know that the studies indicate that they are most often adult children and spouses. Most of the time male. They sometimes have a history of their own substance abuse, mental health issues in general, depression, things that are showing up for them. So they're having a hard time taking care of their own needs. They often have trouble with the police, involved in law enforcement, different sorts of crimes. They're often socially isolated. It's easier not to be detected if you're away from anyone who might assess that. They often have financial problems, and with some of the big financial downturns that have happened in the last 10 years, we've seen these stressors get much more increased for the caregivers, and a number of folks have gone back to live with their parents because they didn't have any other options for managing their own living situation. And that can be extremely stressful for them to be back in the home, could be the back of the home that they were raised in even. And that has a lot of dynamics that go along with it. They, in a study of 4,156 older adults, family members were the most common perpetrators of financial exploitation of older adults, followed by friends, neighbors, and home care aides. So if they are caregivers in the home, is caregiver stress the reason why people abuse? Well, the primary reason is that the caregiver has inadequate coping mechanisms. They have not figured out how to take care of themselves with whatever stresses are coming to them. And then if they had the added stress of taking care of their older adult, that piles on, and they feel like they have no help or no options. And sometimes the biggest intervention is just to point out that there may be some options, and that can often relieve them, just knowing that there is something out there that might help somehow. There's been an argument in the research about whether or not if their caregiver stress is the primary reason why they're abused. And there is some debate, but part of it is the entitlement that comes along with being a caregiver. Part of it is, and especially for older adult children, children caring for older adults, they might actually be able to exert some power. And if they're feeling powerless and they're feeling overwhelmed, and that ability to exert some sort of power can sometimes be one of the reasons. The dynamics that show up, one of which is dependency on the older adult. So the more the person is dependent upon them for a place to live, for food, for other things that they might need, that dynamic can increase the caregiver's stress and increase their inability to cope with their own stress. There sometimes is also the intergenerational transmission of violence. Abused children, they were abused by that person, now have some opportunity to get payback. So that dynamic shows up with this cycle of violence and anger taken out onto the person. The caregiver often has other dependencies in terms of medical needs too. They need to live there because they need to be taken care of by somebody else in the family, or there are children in the family, and they have to have care for those too. So that can all just sort of escalate what might be happening in terms of coping skills for the caregiver. There are cultural issues that show up that affect abuse and what causes the perpetrators to abuse. Some of the things, there are societal attitudes that make it easier for the abuse to occur without detection and without intervention. So you see these things showing up in different realms too. You see these things showing up with cultural behaviors that are misunderstood and interpreted as abuse. We've seen this in school systems where they've seen various religious practices that make marks on the body show up, and the family was accused of abuse because they had this religious practice that nobody understood in the school, and they felt like it was abuse. As it turns out, it wasn't. But those kinds of different kinds of practices can be misunderstood as abuse, or can lead to abuse depending on what it is. Some religious practices like forbid medical care. Some require various different things that one does with the body, or fasting, or not drinking water, or lots of different things that might be misinterpreted as abuse and turn into it, get worse and become problematic. There's often the feeling that the person is not valued, often with older adults, vulnerable adults, and women. The society, various cultures have belief systems in which they're not valued. And so we see that in our current culture with impatience, when someone is in front of you at a grocery line and they're taking a very long time and they are an older adult. We see other people around getting kind of impatient with that, feeling like their time is being encroached upon in some way. There's also the view that what happens in the home is private. Don't talk about anything that happens in the home. Don't even talk about it if somebody asks you about it. So it can be very difficult to get this information, and especially if there is language barriers. It's sometimes a struggle when I see patients to be able to have the caregiver be outside the room and talk to the older adult on their own. Sometimes it's hard to get that caregiver to relinquish that control and go out. And if there is some sort of appearance of impropriety, that becomes even more difficult, and also is sort of a red flag. If they won't let you talk to the person alone, that certainly is a red flag. And language barriers are often significant, not being able to get appropriate interpreters to talk in the session with the person who may be abused, and somebody who is medically trained as an interpreter as well, because there's lots of language that some interpreters are not trained to deal with, and so it's often hard for me to get an interpreter at the VA who is able to actually do the conversation. Things that are considered abuse differ from different places. Some people think it's just fine to eat 1 meal a day, 2 meals a day. There's big movements about calorie reduction. It's a good thing. And whenever an older adult says, "Oh, I only eat 1 meal a day, and that's fine, I've been doing it forever," my first question is, really? Forever? Is it really forever? Is this something that they really believe, this reduction of eating? Or is this covering up something that's going on, lack of money, abuse by someone. And sometimes folks don't even realize they're being abused. They have no concept because whatever the family structure has been abusive, and they got used to it and they don't even consider it abuse. And educating the person is some of the hardest part. To educate them that they don't have to be in this situation, and there are options if they voluntarily want to get out of it, and that kind of to validate their embarrassment about acknowledging anything that's going on, that it's fine to talk about this, and it's fine to accept interventions that might be offered to them. So how do we prevent abuse? Educating the community in general on what's going on out there. I'm always surprised when I talk about these scams that are going on out there in the world with my social group and my family. They really have no realization of just how prevalent it is, and just how many people that they know are being called by people trying to get their money, and or getting mailers in the mailbox requesting their money, or telling them that they've won something and they better send in something so that they can get their money. This is really widespread, and there are so many different scams that you certainly don't need to be cognitively impaired to be hit by one. I've known a number of people who have no cognitive impairment whatsoever and have gotten hit by the computer repair scam, where you are called up randomly, offered your computer to be repaired or upgraded, and they install some sort of a program that then gets access to all the data that you have on your computer, including financial data. And then afterwards, they continue to call you to see if they can do it again. I know someone who's still being called after a year and a half every single week by this person, who already took them for $1,000, and they had to get a new computer. So these things are really, really prevalent, in educating everyone, and educating every older adult particularly, and to provide the resources for how do they intervene. What does the older adult do if they are being exploited, but they don't want to tell anybody? Well, we can give them those websites if they use the computer. We can give them written materials that give phone numbers of where they can call, and there's some resources at the back of this presentation, to empower them to do this on their own, even if they are not really wanting to talk about it or willing to talk about it. And even if they're not an older adult as well. Not an older adult, a vulnerable adult, pardon me. Even if they're not a vulnerable adult. How else do we prevent abuse? Well, social contact and support. Increase the number of people in their lives. So I do this often by trying to get home care in, trying to get companions hired for folks to spend time with them, having them sign up for various programs where people do visitation, reconnect them to their social context if they've kind of lapsed going to their church or their club or where else they've gone. Even the gym can be enough just to get people out and socially active and not home, and less of a potential to be isolated. Also hooking up the families to caregiver support and resources themselves to be able to take care of themselves better. providing treatment for everything that might be going on with them, their medical concerns, their mental health concerns. Also with the caregiver, treating the caregiver for their mental health concerns, and providing resources for them for where they can go to take care of their financial needs, caregiver stress management, all these types of things. The more eyes that are on the person, the better. The other thing is these lifelong patterns of the veterans that tend to isolate them. Alcoholism, not taking care of their medical concerns, maybe their diabetes, letting that go, and that it's always been a struggle for them to sort of manage that. And now that they're alone and isolated, they really don't manage it at all. I'm trying to get these life patterns that have gone unaddressed to become addressed. Multidisciplinary collaboration. That's one really great thing that we have at the VA. And especially on my two teams, we have pharmacists, we have psychologists, we have neuropsychologists, we have psychiatrists, we have nurses who are trained in older adult issues. And we can connect them to specialty medical care and other resources in the community that can provide, just more eyes on the situation and more efforts to take care of whatever is going on. And research. There's not a whole lot of research going on about elder abuse. The resources that are the most common I included in this, and there certainly is a need for more research to be done, and developing more tools for the assessment and for the intervention. The problem is often that when folks don't get assessed, it's because somebody felt inadequate to do the assessment for one reason or another. Asking the question, is it my responsibility to do this? I'm just a pharmacist. I'm just a grad student. I'm just a whatever. And feeling like, well, how much time will this take? If I really launch into this, am I going to have to take them down to the emergency room? Am I going to have to be available for people to call me? Am I going to have to do a bunch of note charting? How much effort is this going to result in? And what questions do you even ask, by the way? The person has dementia. Well, they can't be assessed if they have cognitive impairment. Or, well, what if I intervene and they take them out of their house and their rights are taken away from them and they can no longer live in their house? I'm the one to blame, and that may be something that ruins my therapeutic alliance with this patient. Some people believe that abuse is rare, that it actually doesn't occur very often, and they don't figure that they're going to see that turn up all that often in their own practice. So they think maybe it's medical, maybe it's something else. It's not abuse, it's something else is causing whatever the symptoms are that we have talked about. Or, well, I don't want to do it now. I want them to have a cognitive assessment. I want them to have an MRI and a CT, and I want them to be screened for this and that before we do any kind of reporting. Well, if she has Alzheimer's, she's incompetent, isn't she? So we could just make decisions for her. Competence, not something that we assess in the medical realm. We leave the competency assessments for judges and only judges. Other questions are, well, how do you know if a person who has dementia that is talking about something that sounds relatively psychotic might actually be talking about something that is real. And how can we take that at face value? If they're saying, somebody's coming into their room at night and taking them somewhere and they don't know where they're going. Is that true? Well, it might be. And some people believe, well, what if I start talking about this? Aren't I going to be like pushing my nose into somebody else's business? Aren't they going to be offended that I'm asking all these very pertinent and intrusive questions? And what if the caregiver won't leave the room and I want to talk to the patient? Then what do I do? Am I going to have to do more intervention just to make that happen, and all of those other things? So providers are reluctant to ask about that for many different reasons. And the bottom line is that we are mandated to report. We must report. We must assess and talk to the victim and figure out what's going on. So when we're looking at assessments, talking to the victim, obviously, but determining their safety. Do they have any options? Do they have other people in their lives that they're safe with? Do they have other places in their lives that they're safe to go? Is there a way that they can make a safety plan similar to domestic violence? Is there a way that they can make a safety plan for themselves, or they have trusted persons that can help them make a safety plan to be safe in the home? The one that comes up a lot for me, for folks who are needing to find a safe space in the house, is at what point should they go be in that safe space? Kind of teaching them how to detect when things are escalating and when they need to get safe, whether something might be happening soon to them, either the argument is going to be escalated, or there's some other behaviors that are going to happen with the caregiver or whoever is the abuser. When should they get out of that situation? How should they get to a safe space, even if that safe space is somewhere as close by as a room in their house they can lock the door? Making a safety plan on every level to figure out how to keep themselves safe in any kind of situation that might escalate to actual abuse. Getting the details from them about who's doing the abusing, and as many details in your assessment as you possibly can about the history of this abuse. When did it start? When does it happen? How many times has it happened? And what their desire for help. Are they actually wanting you to help them make a safety plan? Are they participating in that safety plan? And even though they have the dementia, there is ability to talk to them about the specifics of what is happening in very simple, short statements. Has this happened? Tell me about that time. Very simple questions that can get at that information if it's just asked. And most of the time, in my experience, people will tell you if you ask them. Most of the time, they will tell you. And especially if they have a therapeutic relationship with you. The other thing is talking to the suspected abuser. I've had circumstances where the caregiver was doing something that had the appearance of impropriety, or they were considering doing something. The one that has come up several times is putting a lock on the outside of the person's bedroom door. And the caregiver said it with complete and utter misunderstanding that was not the correct thing to do. And actually that's considered imprisonment. And when I spoke with a caregiver who hadn't done it yet, but they were thinking about doing it, and they were shocked that it was not okay to do. I just want to keep the person safe. That's what they said, similar to the cage. I just want to keep them safe. They keep wandering at night. And then, the door then is opened for more conversation about how to make that safety plan. But, and educating them again about what is appropriate and what is not appropriate. When they're doing the best they can, often they don't mean any harm whatsoever, but they just are grasping at straws for what they can do to keep the person safe. You need guidance around that. And I wish I would have known that the woman who built the cage was thinking about building a cage, because we would certainly have discussed the appearance of impropriety and the appearance of a crime. Decisional capacity. When does a person have decisional capacity? Assessing whether they can make decisions for themselves about all aspects of taking care of themselves, financial, big decisions, buying a house, selling a house, other types of contracts that they might want to get into, is tough. In general, it's difficult. But folks who are in an abusive situation and also may have some cognitive impairment, finding out what their decisional capacity is helpful, but the decisions that people make ebb and flow with the capacity. So they may one morning be able to make a decision about buying a car, but then the next day have no recollection of buying that car or wanting to buy that car. And they certainly wouldn't be appropriate then to sign a contract. So it sways back and forth with the decisions that are being made and the time of day, the day of the week. And so decisional capacity is always slippery. And in terms of abuse, APS certainly wants to know whether they have decisional capacity about major decisions with their finances and living arrangements and things like that. But in order to intervene, as long as they're a vulnerable adult, interventions can be started, and further assessment then can be made as time goes along. I would not want to have an abuse assessment stopped because the person doesn't have access to a decisional capacity evaluation. It can be done later on, and it doesn't really matter to get that report going. Assessing their ADLs and their IADLs, it's really good to get that assessment when they're there, because Adult Protective Services is going to want to know, can they do those things and therefore qualify as a vulnerable adult? Can they take care of themselves? And it's, sorry, it just got derailed by my screen here. This is a little bit odd. Yeah, it's working fine, yeah. Assessing their IADL ability, the interventions can also be started right away with getting other home care and things like that into the home. And even if the ADLs haven't been fully assessed, or like they haven't had a PT evaluation or an OT evaluation, these interventions can be started right away. And referrals can be made right away to community resources, even if it's going to take a while to do all of those assessments. Those referrals can be made. Discussing getting fiduciaries and payees for finances can be started right away so they can get going, because those types of interventions take a little bit more time to do. And if somebody's in that situation, it needs to happen quickly. Other interventions are respite. Temporary time off for the person who's providing care. In the VA, we offer respite in home and at an adult day health program and in nursing facilities when we're running. And that can often provide the needed break that the caregiver has to be able to keep going as a caregiver. And we recommend that people schedule these breaks regularly throughout the year, 2 to 4 times a year at least, and have some 24-hour in a row time off, not just a couple hours here and there. Although a couple hours here and there, just having maybe another family member step in or an activity that person is going to might provide a little help as well. That 24-hour is really important for getting good rest and sleep. There are lots of different kinds of respite in the community, and social workers are masters at trying to find these things, and especially things that are low cost or paid for by other systems like the VA, like Medicaid. Senior Services provides lots of different resources throughout the county. Each county has their own system of resources that come from the federal, state, and local for funding resources. And so checking with them is always important. Calling 211 in Washington State is our resource line, and most resources for respite are listed on that, and you can actually talk to a human being. All other different kinds of community events and social engagement is good to get the person involved in, so the caregiver might be able to have just a little bit of downtime as well, and the person is getting some fun in their lives and reintegrating back into society if they have felt like they are kind of stuck. DSHS and the resources on 211 sometimes require applications and eligibility criteria, income, means testing, and things of that nature. So you want to be able to have somebody who's able to follow up on those things to make sure that it happens, and social workers are very good at that. Some other interventions, powers of attorney. A person who is designated to be making their decisions for them if they're not able to make them on their own. In the case of financial power of attorney, a person can designate someone to be their power of attorney even if they can make decisions on their own, if they want to have someone else managing that for them. And then if it's durable, it stays into effect when the person has cognitive impairment, when and if the person has any kind of cognitive impairment developing. It's revocable in that they can determine that they don't want that person to be their power of attorney anymore, and just revoke it at any time and do a new document and just have the previous document destroyed. They don't need an attorney to do this for healthcare powers of attorney. Financial powers of attorney, it's often a good idea to consult an attorney, especially if there are estate issues, if they have an estate or they have a lot of family members that might be wanting to be involved in this decision making. It's good to have an attorney at least consult. And they must be witnessed and most of the time notarized. Some documents don't have to be notarized. The healthcare powers of attorney should go into the medical record, so that anytime healthcare powers of attorney, healthcare decision making is needed, the medical practitioners know who their healthcare power of attorney is designated to be, and can make sure that that person is involved in the decision making. There's some really good documentation on WashingtonLawHelp.org that is a website that is developed by attorneys, and specifically attorneys that often work with low-income folks. So they give really good advice and try to educate people to be able to do these processes themselves, if it's possible, without having to hire an attorney. but they also are kept up very frequently, and you can find those resources on that website, and many others as well. There are now powers of attorney for mental health care as too, that are starting to be utilized out in the community, for people to be able to designate what they want in terms of mental health care and who they want as their mental health decision maker. So this kind of interesting expansion of powers of attorney. Different documents can be found online. Every document is written a little bit differently. There's a core amount of language that must be included for Washington state, but documents can be found online just with a Google search. They can be found with social service agencies. They can be found at stationery stores, Staples, those type of office supply stores sometimes have the documents. And often doctors have the documents in their office to do a power of attorney and a living will, designating what kind of medical treatments a person might want in an emergent circumstance. So they're readily able to be found out there without an attorney's involvement. Another thing that can be done is vulnerable adult protection orders. So these are similar to no contact order. They are protection from a particular person or a particular kind of abuse by that person. They can intervene legally and provide direction to the person who's doing the abusing to not have contact with this person because of this actions that they have done. And anybody who is in the position of having a duty to care for them, so if they are if they are living with the person, they have a duty to care. The person is there in their home. If they, or they are in their home. If they're being left without means, having somebody make sure that that person isn't the one responsible for caring for them anymore can be one of the most effective interventions. The process for a vulnerable adult protection order is online. It's the municipal court. Municipal court? Oh, that sounds wrong all of a sudden. I think it's municipal court. The petition can be brought by any interested person who's interested in the person's welfare and believes the intervention is necessary at this time, and that the victim is unable to protect their own interests. So another family member could open this up, and APS as well, Adult Protective Services, can start the process for a vulnerable adult protection order, also called VAPO. They can last up to 5 years, and the person who is abused does not have to give permission in order for this to happen. It is a court proceeding though, and they may have to be in court when this is brought before the judge. Another legal intervention is guardianship. And guardianship is always directed by a court. Nobody can receive someone as their guardian for their person, their decision-making, their person, their finances, or for particular decisions that are important, like say a surgery that they need, but they're not able to say whether they're agreeable to having it, and the medical team believes that the person needs it, or it's threatening their life. These types of things can be initiated. Guardianship does cost money, and sometimes that is a big sticking point with family members, and it does take a while to initiate the process, 3 to 6 months generally, and there's a very regimented process that happens with the court. When the affidavit is initially ordered, then the judge assigns a guardian ad litem, and they attempt to basically research the person's life, and find out, do they indeed need a guardian? They talk to the family, they talk to the friends, they talk to the medical providers as much as they can. They get that information, make a report, Superior Court, pardon me, it wasn't municipal court, Superior Court. They go back to the judge, and then the judge determines whether that guardian is assigned or not, and if the guardian is assigned for person, for estate and finances, or for a particular decision. Guardians cannot, however, do things like place a person in a nursing home against their will. They can't do that. Or a psychiatric facility without a court order. They have to go through the mental health process, the Involuntary Treatment Act process, in order to be hospitalized at a psychiatric facility. So very often family members think, and caregivers think, that they can do that, and that's why they want to pursue a guardianship. But if the person is not agreeable to go into the facility and behaves as such, the facility is not going to admit that person. There may be many ways to reassure the person that it's okay, and sort of, educate them and see if they're willing to do it maybe later. But as long as they're absolutely unwilling, then they can't. It does not have many remedies outside of adult protective services if the finances are not available. So adult protective services should be consulted, especially if the person is needing a guardian, and to let the APS know that that is one of their needs right away. And who are folks that report? Well, we all are. Anyone who's in the healthcare field, law enforcement, school systems, medical examiners now, and even Christian Science practitioners have been added to the RCW as being required by law to report suspected abuse. Not known abuse specifically, but even if it's just suspected, you can report, you should report, you have to report. And if it appears like the crime has been committed, sexual assault, physical assault, a weapon has been used, the police should be reported as well on those. They can pursue the criminal end and do an investigation for that. The steps to reporting are easy, very, very simple. Can call 911 or DSHS in the county that the person lives in, or the national 1-866 End Harm number, which is a national hotline, and then they will transfer to the local county APS department. If they're living in their own dwelling, you report to the APS directly. If they are living in a nursing facility, assisted living, group home, something that is run, a business that is run for providing care, then they take the reports in the long-term care ombuds service, and the number's on there, and then they will investigate, and they will also report to the police if it's necessary, and then they will do an investigation. If the abuse is happening in the home, particularly, they will do an investigation and determine, talk to everyone involved, and look at records if needed and things like that to determine what was going on and who the perpetrator was, and proceed with that. And they take it very, very seriously, as they should. And it's nice to know that more and more police officers are sort of getting educated about abuse and about what to look for when they go to do an investigation. We are lucky in this regard here in Washington State. So they will, in APS, they will conduct a home visit first after the report is made in the jurisdiction that the patient lives in. They will interview all of the individuals in their life. They will offer the protective services and, like I said, report to law enforcement. If they substantiate the case, they'll assign it to a case manager and determine whatever needs are pertinent to be explored. They will seek emergency resources if the person is imminent harm in a life-threatening situation, to get the person out of the situation. They can also refer for legal interventions with the Attorney General's office for, like I said, for things like financial exploitation, particularly the elder abuse department. There's 2 attorneys that are assigned to follow a case that's reported to the Attorney General. There are other places that can be, the person can be referred to for support and resources as well. The domestic violence resources with hotlines that have people on the phone that are very skilled talking with somebody who's wanting to get out of a domestic situation. I listed the ones that are here in this, nearest here in the area. The Sexual Assault and Traumatic Stress Center for counseling, if they have had sexual assault or been a victim of trauma. The Area Agency on Aging has different resources for respite and for long-term care, to have somebody help somebody with the process of finding a care facility to live in. Also with caregiver support, they have a program there. There's other social service agencies, senior information and assistance, the home and community services to apply for the money to be able to afford a nursing facility if the person is on, or a care facility if the person is on low income. And that is it. You have questions?
Yeah, I do have questions that have already come up. Just trying to unmute. Okay. So the first question is if you have any advice when a state APS won't help. They have a policy where if the person says no, they respect that decision, but this person is entirely reliant on the financial abusers and isolated in the middle of nowhere, as well as some mild cognitive symptoms. So the person has said no, and so APS won't fit.
Okay. So yes, that is true. APS does have a policy that if the vulnerable adult says no, won't let them in the house, doesn't want anything that they offer, they do respect that unless it is a situation of life-threatening intervention into a life-threatening situation. Then they will call in the services that they can invoke involuntarily. So I would look at who else is in their life. Is there anybody in their life that can help with this process? Anybody that they trust that can be with them, be on their team, as I like to call it. Who's in your team? To provide any kind of any kind of intervention that might be helpful. So initially starting with, I don't know, something as simple as visitation to another family member's house for a short time. Get the person out of that environment, then maybe they're more likely to participate in more types of planning. Figuring out a way for them to buy in to the decisions. And sometimes that comes with a therapeutic relationship. If you've been able to see them more than once or twice or 3 times, sometimes they're more willing to do that. Again, trying to see if there's any other kind of intervention that might work. Are there care aides that could come in and help them with whatever the situation is in terms of taking care of themselves, their environment, decrease the self-neglect if that's what's going on. And I would also say repeatedly report to APS. They do build case files, and so if they say no now, I would wait a short time and report again. And sometimes it takes multiple reports before the person will accept whatever they offer, or that they find something more is going on, just because of different people are reporting and they're collecting that in their file. You can look at, are they psychiatrically in need of treatment? Can they be involuntarily treated through the Involuntary Treatment Act process by getting the designated crisis responders to assess them if the person is dangerous to themselves, dangerous to others, or gravely disabled to such a degree that their health and safety are affected. That sometimes will at least get them into a hospital where somebody can take care of them, assess them, and figure out some kind of a plan. Although they do have to meet that criteria, and they are going to a psychiatric facility. So there are particular pieces to that the person needs to know about, that they are going to have to go to court. They are going to have people checking in with them in the hospital all the time. They're going to have to stay for more than 72 hours or 14 days or whatever the judge, wherever they are in the process, whatever the judge determines, based on that legal process. Like I said, I try things like just getting companions in there, getting as many people as I possibly can to talk to the person and see the person and be in the home. If they develop a trust with one particular caregiver, maybe then they'll accept some other interventions. A lot of times the older adult likes the caregiver and will do what they say, but won't do what the family says. So you use that kind of thing as a leverage. Then the person that they trust, the person that they like, is part of their team, and then they can suggest things and see if they'll accept it if they suggest it. Sometimes they'll do things for me that they won't do for family, and for doctors, nurses, and other medical professionals when they won't do it for family. So using those types of ins to help the person buy into whatever the proposed offer is, and see how that goes. Anything that's possible, I would try it and see how far you get, and then try it again. Wait a month and try it again. Propose something to them again. If they won't see like a social worker, if they won't see a social worker, they won't see a physical therapist, have a physical therapy evaluation for them if they'll agree, and see, how well are they able to care for themselves. Get a real assessment done. They might like the physical therapist, and they might agree with what the physical therapist says. Oh yes, you should have more physical therapy in your house. They agree to that. That might be the opening of the door just a little bit, and just keep reporting.
So here's an interesting question, slightly different take. How would you report on an older person who just always makes bad decisions about their health? Maybe they drink, they don't want to be in an adult family home, And so maybe how might you work with a family member who tries to provide care to someone who's sort of engaging in unhealthy behaviors like drinking or not taking their meds?
So the first thing is that a person is, we all are, allowed to make bad decisions. If the person is not a vulnerable adult, if they are just choosing to do whatever they're doing, but they're aware of the consequences and what might happen if they continue to do this, then they're choosing to do it. And we have to grit our teeth because everybody's able to make their own decisions if they are able to make their own decisions, and even if they're bad decisions. But we as professionals can keep returning to the question every time we see them and assess more and more and more about their willingness for change, whether they are contemplating change, whether they are checking out any kind of treatment, whether they have tried to stop drinking and it just failed, and so now they're frustrated. Well, maybe another attempt at treatment is something that they would do. And again, bringing in their team, who's on their team, and talking to the family members about that people are allowed to make bad decisions as long as they are able to make bad decisions, as long as they understand the consequences of the decision that they're making. But educating the family about how to keep them activated and engaged in things. Maybe through that they'll find another path into maybe treatment again. Offering them, things like inpatient treatment, if that's a possibility. Maybe they want to quit, but they don't think that they can do it at home. Maybe there's other different settings that they might try. Maybe it's just a harm reduction approach, and you get them to drink less alcohol content alcohol. Small little steps to kind of help with the larger goal. But yeah, it's hard when you know exactly the path that they're on and where it's going to lead. But yeah, they're allowed to make their own decisions. Now, if they are dangerous to themselves, dangerous to others, and gravely disabled due to a mental disorder, if they are depressed, if they have some other mental disorder that is affecting their decision making, that needs to be assessed by a professional as well, and determine again whether the mental health system is a place that an intervention could be provided. If they make that criteria and the designated crisis responders are called to see them, then they could see hospital. They can also do involuntary alcohol treatment if the person meets the criteria for that. So yeah, that's a tough one. That's a tough one.
Any questions? Any questions? Can I do the hypothetical question?
Yeah, hypothetical question?
Yeah, I have a case on my caseload as of yesterday. 75-year-old female mom.
75-year-old female mom.
Living in a car, been homeless for 2 years. And right now she's parking at the QFC parking lot in Southern County in a boat. But then again, she has a son, who's not allowing her to near to a son's house, and she wishes to see 22-year-old grandson, but she's not allowed. I couldn't delve into what happened before. Maybe some kind of protection order against her, senior, to protect them or something
right.
like that. But still, is my senior, just to give them that short scenario, is my senior vulnerable
So the question is, a 75-year-old living in her car, homeless for 2 years, has a son that is not allowing her to see the grown grandchild, and she really wants to see the grandchild. Not sure what kind of dynamics have happened between the son and her in the past. And question is she a vulnerable adult? Well, so the question is she taking care of her ADLs? Is she bathing, dressing, eating, drinking, walking, managing her finances, doing all those things appropriately?
Not ideally. A lot of bad decision making. I mean, she's in, that situation. She ended up, being in that situation.
Mm-hmm. So I would report. I would report. Yeah. APS goes out. So they have, do you go out in your practice? Do you go out and see people, or they all come to you?
I can do home visits.
Okay.
Hardly.
Yeah. So APS can go out and they can offer her something as simple as food to kind of build that relationship and see what she's agreeable to. Does she want to live in her car, or does she want to live somewhere else? Is she capable of living somewhere else? That's the other question. If she's been living in her car for 2 years, does she even have the ability to live in her own type of environment? And is she willing to go to a supervised environment if that is the need? Is she willing? What's her financial situation? What do you have to work with? What are her options based on that? Yeah. But I definitely would report to get that rolling. Does she have mental health stuff going on?
So far, she has a severe depression. I mean, even to the lay people's eye, I'm not medically confident at all. Make any judgment on that, but I can tell.
Okay.
And then she just keeps saying that, not that I'm suicidal. Not that I'm suicidal. Not that. But.
Well, I would definitely keep a watch on that and reassess for danger to self, danger to others, or grave disability. She may very well be gravely disabled if she is.
She has certain health conditions.
If she's not taking care of herself to a dangerous degree, she could possibly be gravely disabled, but you'd have to assess that a little bit further. Yeah, but then the mental health system might be able to screen her, and they also can go out and do outreach. Yeah. Okay.
Do they do outreach to cars?
Oh yeah.
Oh, okay.
Yeah, they do. Yeah, both of them do.
Okay. All right. Thank you.
Any other questions?
Very much.
Thank you so much for listening.